It is with great pleasure and a profound sense of purpose that I, Parvin Akhtar Chaudhary, BSc Nursing fourth year, um, uh, BSc Nursing fourth year, student of Asian Institute of Nursing Education, stand before you today as your anchor for the track 3 of this remarkable online conference. We have an engaging and informative program lined up for you as we dive into the track 3, which focuses on a subject that is patients for patient safety. So, without further delay, may I take the distinct pleasure to introduce our esteemed chair of track 3, Ms. Kawaljit Oberoi, ANEI EC member and nursing consultant, to lead us through the compelling content that awaits us. Ms. Kawaljit Oberoi, over to you, ma'am.
Good morning, all of you. Thank you for taking me this for introducing me, Parveen. This is my pleasure to be hosting this particular discussion for patient safety. Now, I want to just add one point. Now, from the time I have grown into nursing profession in the days of 1990s, when I had been in one of the largest organizations in India, I was not aware what is SOP or what is quality or what is patient safety because nobody talked about it. Nobody gave any emphasis on that. But then when I went to a foreign country, when I went to Middle East, and when I was asked, do you have SOPs? And then I just wondered, what is SOP? I mean, I never heard of this term SOP. That was a time I was told that there are checklists, there are SOPs, there are criterias, then we have to follow all this from patient perspective, from patient safety perspective. And that was the first time I heard something about quality in healthcare, patient safety in healthcare. I said, oh, this is something which is very interesting. And from that day onwards, I have developed so much of passion for patient safety and patient quality of services that there's no looking behind now. Leading some of the well-known hospitals in India and abroad, I have realized one thing that as nurses, we play a very important role in patient safety and quality of services because most of the time nurses are there with the patients. So now I would like to take my panel through through the well-known personalities who are going to be a part of this particular session. I'll introduce them to you and let us hear what they have to say from patient safety perspective. So first, I would like to introduce Mr. Som Mittal. Welcome, Mr. Som Mittal. He is the chairman for Patient Safety Foundation of India. Looking at his profile, we can say that he is currently a strategic advisor to corporations, governments, academic institutions, trained bodies, and business leaders. He's a former president and chairman of NASCOM. He's a chairman for Patient Safety Foundation, an organization to create awareness among patients. He's recognized by WITSA, Indian Merchant Chambers, and DataQuest with a Lifetime Achievement Award for outstanding dedication to the technology industry. He has received Business Leader of the Year by Rotary International and the Distinguished Alumni Award from the IIT Kanpur. He is honored as a Fellow of the Computer Society of India. Mr. Som Mittal, we are very, very happy and it's our pleasure to have you with us in this session. And we are looking forward to hear lots of good things and very important perspective from you for patient safety. We welcome you.
It's a privilege for me.
Yes. So let me introduce another dignitary with us over here, Dr. Lalu Joseph. You can see only 6 lines mentioned about Dr. Lalu Joseph on this slide, but I have known Dr. Lalu Joseph as one of my principal assessors in one of my NABH assessments, and I have seen Dr. Lalu grown from I've seen her passion towards quality, towards patient safety, towards initiatives she has taken, Kahokon and whatnot. But still, I would say, Dr. Lalu, we are really very, very glad to have you with us over here. And introducing Dr. Lalu, I would not be doing justice by just reading about her, because you will be hearing a lot about Dr. Lalu Joseph, who is now started with the Patient Advisory Council. Dr. Lalu Joseph is experienced in healthcare quality and patient safety with rich experience in implementation at the largest hospital in the country accredited by NABH. She's a program director for many training programs in healthcare and trainer. She's passionate about spreading the wave of quality, patient safety, and accreditation. She's a member of many national and international committees. We welcome you, Dr. Lalu Joseph, to this panel, and we are really looking forward to hear from you regarding something new, which is called as Patient Advisory Council.
Thank you so
My
much.
pleasure to have you, Dr. Lalu. Yeah, I'm very happy to see you over here on the same dais. The next speaker.
Thank you very much, Kawaljit ma'am. It's a real honor. Thank you.
Yeah. So our next speakers are going to be Dr. Donna Passer and Mrs. Olivia Lunsberry. They are our international speakers. I would like to introduce each one of them separately. Dr. Donna M. Prosser, she is Associate Principal Reliability and Management Systems, Raleigh, North Carolina, USA. Dr. Donna's area of expertise include hospital operations, transformational leadership, performance improvement, and implementation of high reliability systems. She's an ex-chief clinical officer at the Patient Safety Movement Foundation, USA. Dr. Donna holds a Doctor of Nursing practice from the University of Central Florida, a Master of Science in Nursing from Duke University, and a Bachelor of Science in Nursing from George Mason University. She is a fellow in the American College of Healthcare Executives, is a board-certified nurse executive, and is a certified Lean Six Sigma Green Belt. We welcome Dr. Donna in her absentia because of the time difference. She would not be joining us in person. Same with the next speaker, Miss Olivia Lunsberry. She is a Quality and Safety Program Coordinator from Johns Hopkins Children's Center, USA. Olivia Lunsberry is currently working in the Quality and Safety Department at Johns Hopkins Children's Center in the US and in the Department of Surgical Sciences at the University of Oxford in the UK. Outside of her full-time roles, she also serves as an editorial assistant for the Journal of Patient Safety and Risk Management and Committee Lead for Patient Safety. For Patient Safety, US National Patient Safety Oversight Committee. She graduated from Georgetown University with her master's in clinical quality safety and leadership with an emphasis on human factors. Dr. Donna Prosser and Miss Olivia, they have been instrumental in bringing together the collaboration of ANEI with the Patient Safety Movement Foundation, USC. Though they have moved on to other organizations now, they're still in the patient safety domain. They could not join us live due to the difference in time zones. However, the recording of the discussion is here with us. They are bringing in their experience in US and UK. So we welcome all our distinguished panelists and our speakers with us. So let us start our discussion with Mr. Som Mittal. So we would like to hear Mr. Som Mittal.
Right. Thank you so much, and it's a privilege to be. Yeah, why don't you complete, please?
Yes, talking about patient centricity and involvement in critical to safety, sir. This is a very important topic. We would really want to hear from you.
Varsha, can I have my slides on, please? Yeah, so thank you very much for inviting me for this. And at the outset, to the entire nursing fraternity, a big thank you for what you do. We understand how tough your job is, but you do it tirelessly around the clock, and that's so gratifying to us. I come in here not as an expert, I come in here as a patient. I come in here someone who has had avoidable harm. And hence, but when I look at all of us today, I see 500 odd people who are registered here, maybe many others who are online. One thing is common between all of us, that all of us are either patients or caregivers. So while you might be a nurse or a doctor, that's one role that you play. But the other role that you play is it's a body. We will always have some issue or the other, or we are taking care of someone. So I think it's important for us to, as we go through this whole day, to also put ourselves in the shoes, besides being a nurse, being on the other side. I think in spite of all the good efforts put in by the healthcare providers, doctors, nurses, harms happen. And these harms, some of them are avoidable. Kaho, the healthcare providers, Lalu is here. She does so many training programs, all focused on this area. But it is very important that patients play their role as well. So one is about involving them by you. Other is patients involving themselves. Can we go back to the previous slide? I'll tell you, Varsha, when to move, yeah, please. So if we are alert, if we are engaged, then I think we can help you. So our job in this foundation that we have created, Patient for Patient Safety, we are here not to tell the medical fraternity what to do. You know our job, you're doing all the best that you can. It is for us to play our part to tell patients how to get involved. So I think we are partners with you in this journey. We will take the job of telling our community of patients and caregivers how should they get involved and what their rights, responsibilities are, and what else can they do. So that's basically what my presentation here is. So if you look at this slide here, it's, we treat patient because we're treating a disease, because our focus is what is the ailment, and rightly so, that's the focus, we get him well. But at the same time, there are so many queries that a patient has. Is my symptom serious? What should I tell my doctor? Is the diagnosis correct? Are all these tests that are being prescribed correct? These questions are the ones that come to me and should be coming to most patients every single time they enter a healthcare facility. And the question for them is, where do I get these answers, right? And that's a stress that comes in. Can we have the next slide, please? So if we started mapping the patient journey, and the patient journey starts with us feeling a symptom. We have a symptom, and then we say, is the symptom serious? And I don't know about enough, right? So I keep postponing it. I'll probably take a self-medication. And in the process, there's delayed diagnosis. And that causes harm. So while we're talking about harm that gets caused in a hospital or a medical situation, a harm gets caused even before. So how do we educate ourselves on how to treat symptoms? Not every time should you be running to a doctor or a hospital, but there are times that, so I think that education is required. Then you get to the doctor, and doctor has 10 minutes. We spoke so much about how short the time is. What should I tell the doctor? People struggle. They have 10, 15 minutes with the doctor at best. Their records are not there. And in the process, we provide incomplete information, and that incomplete information leads to a maybe incorrect diagnosis. So there's a part that the doctor is playing, and there is a part that the patient is playing. Treatment options, is it surgery, is it medicines, and we keep dilly-dallying on it. And sometimes we don't even comply, right? Because there are certain guidelines that are given. So I'm first putting ourselves into these red boxes saying, can we prevent it ourselves? Because if we don't do both the sides, it won't work. I have post-care recurrences happen. Do I continue my medications? How long? And people have a very heightened responses when they come out of a hospital, but soon after they go down. So I think if you look at this whole, every stage of the patient journey, we have issues. As Patient Safety Foundation, we are picking up each of these stages of a patient journey and guiding patients what they could do. And we need your help so that we can tell patients what can they do, right? And I think that is one ask that I will have from you. Can we go to the next slide, please? So nurses actually play a very, very critical role in this place. And if you look at the previous slide, I had said, communication becomes a very major area in this. Somebody in the previous session spoke about, is patient not a customer? Yes, I think patient is the customer. The customer is the one who pays, gets a service. But it's more than being just a customer. The patient is stressed. As a customer, I'm not normally stressed. I don't go and come to the hospital by choice. I come in an emergency. I haven't planned my expense. It's an unplanned expense. I do not understand all the language you speak, right? So it's a customer plus, plus, plus. And if that is the case, you as nurses play a very important role. You are the critical point. You are helpful in our execution of treatment. You are the main communicator and the educator for us, right? The doctor has limited time and he actually passes on to a nurse or a paramedic to do this. The assessment, the monitoring, providing comfort, care, compassion, the list goes on this. And at the same time, as somebody said before, you are overburdened, but your smile and empathy, the morning that you come into a hospital room and saying, good morning, did you sleep well? It just changes the atmosphere in the room. And I think that part plays. So there is a technical part, there is a empathy part, and there is this emotional need that you all feel. I can only, on behalf of the patient community, thank you for what you do. And we've seen all the time you're running around trying to do. And there are times we have patients who are demanding sometimes unfairly. And I think our job is to also let them know that that's not a very responsible way of doing it. Next part. So here in this part, I think it's important for us to say, how can you help us patients, right? And I think there was a lot of discussion earlier about wrong medication. So we are not getting into the space of what the hospital's SOPs will be. I think that's your job. You are the best people to do it. Kaho, Lalu, and all the training programs that you all attend, I think will prepare you for that. But I think you please help us in encouraging us to ask questions and have an open communication. Sometimes because you're rushed, you pass it off and we get scared. A lot of us are scared asking questions to the doctor, sometimes to the nurses, because we might just get a response which is not palatable, or it's we're not encouraged. Please do educate us about treatment plan medications. We don't understand your terms. We don't understand your abbreviations, right? Yes, as Patient for Patient Safety Foundation, we will do it. But, it is important that you explain to us our documentation, reports, side effects of medications. We don't know what's going to cause us dizzy. Today, if I read up on the Google, almost every medication, they will give me 20 similar things of saying possible after the side effects. But that doesn't mean anything. You know exactly which side effect at my age to look after. Similarly, you take good care of us in the hospital, but we go home, we don't have the same infrastructure, right? What can we do at home? How can we prevent falls? How can we prevent infections? Because we have seen a fairly high rate of readmissions. Readmission is yet another way of judging patient safety. And that happens because, it is not the same environment, but if you educate us, we'll be pretty good with it. And the story just goes on, I think, emergency protocols and so on. Next, please. So how can we help you? And I think we can be helping you. So I think it's a two-way game. Be polite and respectful, share complete history with it so that you know our condition, tell you about our allergies, verify ourselves whether the identification band and the marking that you do for surgery is right or not. That's the second time our caregivers or we could do it. Our maintaining our health records and following the instructions. We also can help you by observing and learning from what you are doing and build our own capabilities. And hence our logo at Patient for Patient Safety is, it's my health, my responsibility. So we are not saying it's all yours, it's mine as well. And you have to help us in educating that by telling us what we should educate with. Next, please. So this is some of the samples of what we have done. We have made a small little poster here that you see on the left-hand side, which is how do you prepare to meet the doctor. so that the doctor is very efficiently able to look at everything, come prepared. What is the role of the caregiver? You just can't be sitting and sleeping at night as an attendant, but there is a role that you play. And then we have also said, how do you prevent falls at home? Now, this is our part of the job to complement and supplement what you do. And we have a large number of these posters and so on our website. We urge all of you to look at it both as a patient and also tell your patients that they could be leveraging all the data and work that we're doing. By the way, we are working very, very closely with healthcare providers. We are tied absolutely with them to get this done. Next, please. So what happens when we get engaged, right? And I think it's a cycle. First, because there is an early detection, we can prevent, we can cure. And if that happens, we have better outcomes. There are reduced medical errors. And once the first two happen, it improves the satisfaction levels and the trust in the system. I can say as a patient, the trust levels are not very high right now between the patient and the caregivers, in spite of all the good work you do. For you as doctors and nurses, it's also a personal and professional fulfillment that somebody came, he got treated well, and they went back happy. And that earns loyalty. It brings in, amount of trust that gets developed, which helps the reputation of the hospital go up. And that means you're getting more and more people coming in, which improves your profitability. So it's a win-win situation. We as patients would get better treatment, safer treatment, and everybody in this cycle is actually benefited. So, it's not about you must do it. It's, I think, a win situation. Next, please. And I have just a minute to finish this. So we think we need to pledge ourselves, both sides, as healthcare provider and as a responsible patient, to say that we will promote the rights of a patient. We would work towards their safety. We would create an environment of trust. We would ensure that the best quality treatment is given. We will protect the healthcare information. We would not discriminate at all based on caste, creed, gender, economic status, and always adhere to the professional standards. And at the same time, the patients have to pledge on their own active participation, their being accurate and complete when they give the patient history, follow prescribed plans, respect the right and well-being of the property of the nurses and the doctors, be respectful there, and also fulfill my financial obligations. If I'm coming, there is an expense to it, I should fulfill it. Now, it's very easy for me to put all this and put it on a piece of paper. They can be posters all over. But I think what we need to pledge is in spirit and not in letter alone. And I think that's important. It should not be that this year, because WHO talked about elevating the patient involvement, that we are all talking about it. This whole year we'll talk about it. But I think it's important that we adopt it in spirit, right? And I'm sure with all the efforts ANEI doing, I think they'd be able to get there. Last slide for me. Next, please. So in conclusion, I would only say you play a vital role in our well-being. Please involve us. Please involve the patients. Patients are most comfortable communicating with you. You can see it. Every caregiver only talks to the nurse. Doctor saab ko ye bol dena, puch lena. Please encourage them to ask questions, right? Patients understand your guidance, but they don't understand your terms. Please reconfirm if they understood, right? You are rushed, so you'll speak fast. Maybe some of you, as your SOPs, can actually keep a paper which is ready, which you can actually give them. You know how to prevent harm, please share it. You know where the harm. You have got so much experience. Harm may happen to me only once, but you have seen harm happening so many times. Can you please share that, look, this is the way you can prevent it? And lastly, we as patients are stressed. The whole family is stressed, except for people who come for a birth of a newborn, and which is a happy event. All the others come stressed. And your empathy, I would say, is magical. It does wonders to patient. So please keep doing the good work that you are. We are partners of yours. Let's ensure that keeping safe is a priority. And in spite of all the rush, in spite of everything, we are going to work together to ensure that the odd numbers we have of 1 in 10 harm being caused, let's make it. I hope, I'm not sure, Laluji, one time we should be talking about parts per million rather than 1 in 10. So all the best, and we are partners with you. We'll keep working on it. Thank you.
Thank you so much, Mr. Somal. You have really put a very good points across. And I must say that, engaging patients in their own care is really very important and makes a big difference. Just want to share a small example of my personal experience with my mother. She is now 85 years old, suffering from Parkinsonism from last 2 years. During her era, she knew nothing about smartphones or about digitalization, about Google, nothing. But when we showed her how to do it, today she can teach me on Parkinsonism. She knows everything about her signs and symptoms and the medications. And she will tell me these are the medications, these are the side effects. I'm supposed to be taking on empty stomach after food. The doctors didn't tell me, no one told me. She tells me, you didn't tell me this, but I know everything. So really, I must say that getting involving patients, educating patients about their own health conditions, about their about their what to expect, it really makes a big difference. But the flip side of it is you expect certain side effects to happen and you start imagining also. Yeah, that is also another problem. So yes, engaging patients is really very important. There is no doubt about it. But I would like to know from any one of you, after we have started talking about these concepts about involving patient in patient care and all that, is there any statistical data of whether how much of patient harm has been reduced because of these concepts and because of these initiatives what have been taken over a period of last few years?
And I'll just give you one word for us in our context in India, right? Doctor is God, right? So we just put ourselves in the hands of the doctor and nurses, and that's where it ends. I think we have just about started this journey, in my opinion, on patient involvement. We are caregivers, all our families. I'm 71 plus now, right? So we have had family issues, but I can tell you our involvement has been rather low. So it's too early to take the statistics. And as somebody in the previous session mentioned, it's a journey. We are committed to that journey, right? It's a long haul. And it's a long haul in India, given the diversity, languages, gender, literacy levels. So we need a lot more patience and a need to work together. So we ourselves have translated a lot of our stuff into 12 languages because there's no point of our doing it in English language.
Right. And I agree with you completely when you said the nurses play a very important role and they should be supporting, they should be educating patients, they should be encouraging patients to ask questions. Doctors don't have much time in their hand, nurses are always with the patients, but they should be encouraged, like Tankam, told in the previous session, requesting the doctors, please encourage the nurses to start talking. There were days during my time when I was nursing director of one of the hospitals, and intensivist told me, tell your nurses not to open their mouth. We are the ones who are going to talk to the patients everything, because what they will say will create a big problem for us. And now we have come to this status today. We say that please ask the nurses to open their mouth and start talking. So I think it's a journey and we have really come a long way ahead. Thank you so much, Mr. Somital. Hearing you was a pleasure. I request Dr. Lalu Joseph now to speak about her initiatives and her experiences. And I would love to hear from you, Dr. Lalu, about Patient Advisory Council. Over to you, Dr. Lalu.
Very good morning and thank you very much for this wonderful opportunity. I bring greetings from the Consortium of Accredited Healthcare Organizations, the Christian Medical College, Vellore, and now the Patients for Patient Safety Foundation as well. We are indeed very happy and privileged that we are partnering with Annie and trying to spread this message of patient safety and patient involvement in care and delivery. So this is going to be a very I'm extremely happy that you have brought this topic to the forefront And who else can do a better work or justice to what we are talking about? Nurses were, are, and will continue to be the spine of the healthcare delivery system. And whatever we talk, whether it is the accreditation, the patient safety, or the newer concepts of patient engagement, cannot be implemented or be successful in any healthcare setting without the involvement of nurses. We certainly appreciate and acknowledge the contributions of all the nurses working in the healthcare delivery. And I echo the sentiments of Mr. Somithil, where he mentioned about nurses playing a very critical role. And we thank you for your invaluable contributions. With that, let me begin with my talk on Patient Advisory Council. Now, everybody wants to know about this Patient Advisory Council that we are talking about. This is not a new concept. This is certainly a new concept in India. I'm going to share my screen and start with my talk. Yeah, thank you so much. Yeah, so my talk is going to be on engaging and elevating the voice of patients through this concept of patient advisory councils. So I will take you through what these patient advisory councils are, how do we set it up, what are the benefits, and why do we need it? So in an order, I would say that I'll start with the importance of this patient advisory councils. So the most important thing that we as healthcare providers come across is the difficulty in managing patients, all of us, whether it is the administrators, the doctors, the nurses. It is mainly because of the lack of communication in all aspects. So starting from the time the patient comes in till the time he leaves, as Mr. Somithil says, they really don't know what to expect. They come here with a very open mind. They think that they are going to be treated like the way that they are going to be treated in a hotel. So it's totally different, the hotel versus a hospital, but we both belong to the service industry. So the service component comes into highlight when patients come into the hospital, and even a food which is not served hot becomes a matter of concern, and that is taken out of proportion. Now when that happens, everybody runs around, tries to sort out things, but we don't really get into the nuance of how to sort it out. That's where all of us make mistakes. Now WHO has this year brought out this theme of patient engagement. Though it is for patient safety, we also have to start talking about patient engagement in experience, in service excellence. So it is both ways with safety and service excellence. So there are various problems that we face when we don't have a proper system in place, when there are medical errors that happen. There is a huge problem after that. Everybody runs around. We have never calculated the cost of poor quality. We know we are in an industry where errors happen every day. The best example is Sridevi's mother, who was operated on the wrong side of the brain in one of the leading centers in the world, Sloan Kettering in Manhattan. And if it could happen there, we can imagine the situation in our country. We all know the data that 1 in 10 patients who get admitted get harmed. And this is the Western data, the developed country data. Imagine in our setting where we are in a developing country, we are in a low and middle income setting, and we have huge problems. We don't have data at all to substantiate anything. So we know we have problems, and we know we are not capturing data. So how do we sort this out? The best way is to engage with the patients. Engaging with patients to elevate their voice and concerns, it requires a multifaceted approach. Open communication, inclusivity, respect for patient experiences and perspectives. Some of the strategies to achieve this includes, of course, our patient surveys and interviews, which we are all very good at. We do the patient feedback surveys, all that. Fostering open communication, we talk to our doctors, nurses, encourage them to try and talk to the patients and get their perspectives. And one of the very important things that we are going to be advocating this year and in the future is the patient advocacy programs, developing them, and focus on what is known as the PREMS, patient reported experience measures. Of course, we continue to do the education and support that the patient needs. These are some of the ways by which we can engage with the patients. Whatever we talk about, the best thing that we should be focusing on is to set up and establish the Patient Advisory Council. I will quickly talk about what these councils are. The Patient Advisory Council, they actually are a group of individuals who have first-hand experience as patients and caregivers. It is in many countries called as the Patient and Family Advisory Councils. Patient Advisory Council will give the patients a platform to voice their concerns and contribute to decision-making process. You may ask me, everywhere we have the feedback boxes, aren't we giving them the opportunity to speak? Our doors are open. Anytime the patients can come and speak to our doctors, administrators, nurses. What is this more than that? This is a very formal structure where we are getting not every patient, but patients who can actually contribute to the well-being of the hospital, how we can engage better. They give good advice and feedback to us. Such patients are chosen and they are brought into the advisory committee, maybe 3 or 4 patients. But how do we go about doing that? How do we select such patients? How do we formalize this program is what we are talking about. So what are the goals of this Patient Advisory Councils? It's working together in a very structured way to improve communication and build trust. We have huge trust deficit in this country between the providers and the people who actually take care. We want to get valuable feedback from them, from their insights and voice that can be understood in a better way. Because when we go as patients, we have different expectations. And when we are healthcare providers, we talk in a different tongue. So it's extremely important that we listen to them, understand from their perspective what care delivery is and how it should be. Providing a platform for two-way communication, not just banking on our own perceptions and our own intuitions. Preventing adverse events, medical errors, and patient harm. PREMs play a huge role in this particular aspect of preventing events, medical errors, and harm. You may ask me how. When as a patient he is engaged, then he will be more concerned about his safety. I went for a surgery a couple of months back for my right eye. And the first thing that I asked was, have you marked the surgical site? Why haven't you marked? Then they came and marked the day before the surgery. The next day morning, I double checked, I triple checked, and I ensured that that was the eye that was operated. So if I'm an engaged patient and I'm completely engaged in what is needed for my safety, then errors can be avoided. So that is what we are talking about when it comes to patient engagement. Now, how PREMs are going to be useful in this? We have SOPs, but we never check whether these SOPs are implemented on the ground. If we ask the patients the right questions, did the doctor talk to you? Did they mark the site of the surgery the previous day? Did the nurse actually check at the holding bay? Did the doctor double check with you the site of the surgical marking? Then we know whether the protocols are implemented. So by PREMs, these are questionnaires, structured, validated ones, ensuring that we ask the patients whether pertinent things were done for their safety. Now, the most important thing that we were talking about, I digressed a little bit to PREMs, is the Patient Advisory Councils. The primary purpose of this council that we are trying to set up in our hospitals is to hear the voice of the patients and by being inclusive, by getting them talk about their concerns and getting to know from them their concerns. Is it a new concept I mentioned earlier? It is not. It's an existing concept in developed countries. Reports suggest that 38% to 55% of acute care settings in the US have PFACs, which is the Patient and Family Advisory Councils. In Canada, PFACs are convened at the family practice level, not at just the hospital level, at the family practice level, even the GPs, and at the regional and provincial health authority levels, which is like our state and the central government levels. Are we ready? This is the biggest question that we have to ask ourselves. Are we inspired? Are we passionate to spend time and resources for Patient Advisory Council? Any hospital that wants to start the Patient Advisory Council has to ask these questions first. But at a national level, are we ready? I think the time has come. which is why it's extremely crucial that organizations like CAHO, Patients for Patient Safety Foundation, ANI, all of us come together as decision makers, as policy makers, to try and impress and stress upon this concept with our hospitals, because this is the need of the hour, engaging and listening to the voice of our patients. I'm just going to take you through just 8 steps of how to set it up. First, we must remember it's not a mandatory process. It's a voluntary process. And that's why people like us are very crucial to push this concept forward. Now, your hospital wants to start it. You as a healthcare leader, you as a person engaged in healthcare delivery want to start it. You are convinced. What do? You form a very small informal group. You will have different people in your organization, maybe a doctor, a few nurses, interested in this concept. Start talking to them. Come together as a very informal group. Then you go talk to your CEO, COO, your nursing director, and try and initiate this program in your organization. If you are a decision maker already, if you are at a CEO, COO level or a nursing director level, you can initiate the program yourself. But remember, the involvement of the top management is a crucial step or a must for the success of this initiative. So you have to convince your leadership to start this PAC. So that is step 1. Now we are going to step 2, which is activating the core group. We talked about the core group coming together. So the second step is formalizing that core group into a group that's actually going to work on it. So the core group should get inputs and buy-in from key stakeholders while forming the PAC. Now you have convinced your leadership that this is needed. You have to start talking to departmental leaders, other people, opinion makers, decision makers, and try and convince them that this is crucial. And this core group should assist in developing a structure. If we don't have a structure, if we don't have written guidelines as to how we are going to go about, then this will never take off. So you have to develop a structure for the PAC. How many members, who are all the people going to be the members, and also supporting the leader in identifying the right members for the PAC. Putting down the vision, mission statements, and also the bylaws of your patient advisory council. And you must understand that we need minimum number of people in the patient advisory council representing the healthcare professionals. We need more patient representatives. So those 5 or 6 people who are going to be forming the healthcare professionals representative in the core committee, you will have to play a key role in deciding on that. Coming to step 3, which is determining the composition of this PAC and how do you go about recruiting members. If you're a very large hospital, then you need a large PAC. You may even need 2 or 3 PAC. You can have one for surgical, another one for medical, but while we are starting, we are encouraging for the whole organization one patient advisory council. While you are deciding on that, consider factors like the patient population, the hospital, the community that you serve, the type of services you provide. You may be a major cardiac or a cardiothoracic setting. So you may want to encourage patients from that service to be part of your patient advisory council. Yours may be a maternity center. In that case, you may want to bring in parents who have delivered in your setting, the relatives of such patients brought in to the patient advisory council. So it's all up to you. There is no written rule, but it is up to you to set up the composition and be very flexible. Be very specific to the context of your organization, the culture of your organization, and it is up to you. It is not any hard and fast rule. The step 4 and the most important role is to identify the leader and the facilitator and also the members, the healthcare professionals who are going to be part of it. You have already identified the healthcare professionals, but here, who is going to be the leader? It need not be the CEO, COO who will be taking the lead for this PAC. They can nominate, preferably a clinician who's part of, of the organization. And you will know there are several doctors, senior people who are decision makers, who are very passionate about this, and they keep talking about the need for patient engagement. And such people who are open, who have a say in the organization, should be made as the healthcare leader to lead this initiative. He or she will be the chairperson of the Patient Advisory Council. And together, you can decide on the healthcare professionals who are going to be members. And this person will serve as a bridge between the leadership and the Patient Advisory Council. It's very important because some financial and resources, other resources are needed. So as decision makers, these people may be able to add value. And they also should be in a position to implement the recommendations that are brought forward by the PAC. Now, another important task is to identify the facilitator or a secretary for this committee to keep track of the meetings, agenda, minutes, and the action taken. The step 5, which is the most crucial step, is to identify the family representative or the patient representative into your committee. It's a voluntary process. You can try and choose from present and past patients with long stay. You can identify from your hospital data. You may also know certain patients who keep coming to you and who keep coming and they come and give you certain advices. You could do this better. Why are you keeping curtains like this? Why don't you come at 7 a.m. and start your rounds early? It's easier. There are certain things that they keep talking to you about. Such patients with constructive ideas, not criticizing all the time, will be the best people to be part of this committee. Try and identify from diverse background, different language speaking patients, different gender, different locality, different disease condition. So you can try and identify from diverse background. And they should be prepared to represent the patient and the family perspective in the PAC. Another important step is to develop the charter. When we talk about charter, it's a written document that outlines the purpose, objectives, membership, frequency, decision-making process, all that. The core group, while starting itself, would have started writing it up. But as a committee, before you start, you have to clearly write down this charter. And the step 7 is to train and orient. Like the way you have a IRB, Institutional Review Board, and all members should be proficient with the guidelines, how to take decisions, what is the way in which you take a decision. This also involves training and orientation. And all members of the PAC should go through the bylaws that you have written down, the charter that you have written down, how to communicate, methods of quality improvement, what are the various tools, because here this is an improvement exercise. So everybody needs to know the various basic concepts and how to work effectively as a group. And what the PR, which is the patient representative, should not be doing. Mandating policy. We need this policy implemented. They cannot be jumping and shouting and saying this is something that has to be implemented. Get involved in issues of clinical protocols, clinical pathways. Ask for favors or financial aid for their own or for their acquaintances. Very aggressive, abrasive, and non-congenial attitude. So we have to be very nice and polished in explaining to them that these are things that you should not be doing. But how do you do that? It involves a lot of talking to them, not in a direct manner, but in a very indirect manner. Now you're ready to launch your Patient Advisory Council. The size I mentioned, it's not set on stone. 2 to 20 members, ratio 1 staff for every 2 or 3 patients or up to 4 patients. Meeting frequency 1 in 2 months at least. Better to have it even once a month. Tenure, don't keep it forever, 5 years, 6 years. Keep it for a period of 2 years, and therefore you can keep changing people. Of course, the renewal every 2 years. Schedule regular meetings and implement the communication plan. Don't just keep it in paper. Have the meetings regularly. Get everybody involved and make sure that you minute them, the action taken as per what we do for any of our own committees. It cannot be a committee on paper, come, eat and tea. It has to be a very well functioning committee. The roles, I'm not going to get into it in detail. I did talk about it while I was presenting. As a member, as a patient representative, they have to understand the mandate of this committee. They have to commit time and be present. They have to engage with a larger community and bring their perspectives. They have to facilitate the communication between the hospital and also the community, which is the patient community. And they have to collaborate with the healthcare professional representatives or the committee. What is the role of the representative, the healthcare professional in the committee? They have to understand first the mission and vision. They have to commit to active participation. They have to bridge. They have to be a bridge between the clinical perspectives They have to communicate the clinical perspective to the patient, why we are doing it, facilitating the collaboration, engaging with the other professionals in the hospital, supporting the implementation of these initiatives, and promoting open communication. The role of the facilitator or the secretary is again crucial. Actively engage in this, getting the participation of the members, organizing and leading the meeting, facilitating collaboration and communication between the members, tracking the progress and being accountable, supporting the members, and also ensuring implementation of the recommendation through the leaders. And if we don't measure, we just cannot manage. So what's important is to measure the performance of this committee. This may include specific changes in hospital policies and protocol based on what you've heard from the Patient Advisory Council, improved patient satisfaction scores, other measurable outcomes related to patient safety, or any other aspect that you have implemented changes based on the advices. The very interesting thing and the important thing that all of us must remember is to celebrate success. Even very small changes made, have some coffee together, publicize that in your weekly news, your newsletters, get the community to know what you have done, and any small changes, any improvements, celebrate them well. So the most important thing that all of us remember is the success of such, should remember is that the success of such councils ultimately depend on the commitment and active participation of all hospitals, healthcare providers, patients, and their families. A collaborative effort involving all stakeholders is crucial to create a patient-centered healthcare environment that leads to better outcomes and enhanced patient experiences. We commit to join hands with P4PSF, which is the Patient for Patient Safety Foundation, to take this initiative forward. And today we are extremely happy that we are going to be joining hands with the Annie as well. And we are proud that, this country has so many committed individuals working pro bono, coming together for the sake of patient safety. Thank you so much for this wonderful opportunity given to me. I will be sharing through the chat box the link of the Patient Advisory Council white paper and also the PREMS, so that the nurses here, the participants here, can download and read more about that and also start implementing this in their setting. Thank you so much, Kawaljeet and Annie, for this wonderful opportunity.
Thank you so much, Dr. Lalu. It has been really a great pleasure. I think the way you have put up step by step the process, I'm sure most of the hospitals across India are really definitely going to get benefit of this presentation. And so nice of you sharing the knowledge, putting it in the link, and I'm sure people will know how to go about with it. And we are looking forward to lot of hospitals across India to have such committees, though it is voluntary. I'm sure people will definitely want to, take it, embrace it. So just a small thing. One of my experiences in 1990s when I was in one of the hospitals again in Mumbai, I wondered why the CEO is calling people from the community every Thursday between 3 to 5 p.m. and giving them tea and coffee. So I was wondering, what is this all about? And now I realized that, means I realized that time as well, we used to call them as focus group. They would just come and chat with us, tell us their problems, tell us their community problems. I think things have been there in the country, like you said. People are taking it at their level, at whatever stage they want to take it. But now with this formation of PACs, it will get formalized. I'm sure most of us and a lot of our organizations are definitely going to get benefit out of it. Thank you, Dr. Lalu. I could see and hear that passion. I did not want to stop you because I wanted you to take us through every slide. Thank you so much.
Thank you so much, Kawaljeet.
Yeah. So now we come to our next speakers, Dr. Pausar and Olivia. Of course, they are not here in person with us. So I request their videos to be played so that we are able to hear what they are saying about patients for patient safety dialogue outside India. So let's see what happens outside our country regarding this aspect. Thank you.
Hello, Annie members, healthcare professionals, and students. Thank you so much for having us here today to talk about patient.
I will just confirm that they are audible.
Yes, they are audible. Yes.
Thank you.
for patient safety and what work is happening outside of India. My name is Donna Prosser. I am a nurse by background. I'm currently a healthcare consultant in the United States. And my focus is on creating highly reliable and resilient systems in healthcare so that we can make patient care safer. I am very passionate about this work from my time as a nurse, as well as a hospital leader and administrator, and a patient family member who's experienced harm. And so with that, I'm going to pass it over to my friend Olivia to introduce herself.
Hello, everybody, and thank you, Donna. Thanks, everyone, for having us here today. Very excited to get to speak with your group. My name is Olivia Lounsbury. My impetus for involvement in the patient safety space resulted from my own experience with leukemia when I was very young. So I started out by going into the advocacy and policy space and have dipped my toes in research and in sort of operational quality and safety work. Currently, I'm working at Johns Hopkins Children's Center here in the States, as well as the University of Oxford's Department of Surgical Sciences in the UK doing safety research. So I'm very excited to learn from all of you and excited for this discussion. So Donna, I know that we are talking about engaging patients in patient safety and essentially what nurses can do to help engage patients in patient safety. And, you know, as we were reflecting and preparing for this discussion, we were really focused on one key and pivotal organization, at least here in the US, which is Patients for Patient Safety US. And that name may sound very familiar because there are a number of other Patients for Patient Safety groups in different countries. I know there's one in Ireland, et cetera. And we really kind of wanted to structure this discussion around what Patients for Patient Safety US is doing and what that looks like in other areas of the world. So we'll be specifically talking about the US and UK here. And, you know, throughout this discussion, we'll be, you know, centering this on, you know, how can nurses globally help move forward some of these key priorities for PFPS. So I'll just kind of touch on, you know, a little bit of background about PFPS, and then we can jump into some of their strategic priorities here. So the mission of PFPS US is to implement in the United States the recommendations of the WHO's Global Patient Safety Action Plan 2021 to 2030. So for those of you who are unfamiliar, you can download that very quickly from the internet, but you'll notice that as we're going through some of the PFPS US specific priorities, they are very much informed by WHO priorities. So PFPS US started relatively recently, and we really, you know, it was a homegrown effort. Many of our founders who were patients and family members or have been affected by preventable harm in healthcare really got together and synthesized their voices and expertise and passion. And, you know, from there, we're working with a number of different stakeholders across the US and global healthcare landscape to make Patients for Patient Safety US what it is today. Donna, do you want to introduce the first PFPS priority and then we can go on from there?
Absolutely, absolutely. So yeah, so Patients for Patient Safety US has 5 specific priorities that we are focused on. You know, and you know, as Olivia mentioned, this is a completely volunteer organization. Olivia and I are both members of this organization, as well as other patient safety champions in the United States. And what we're trying to do is help folks, number one, see patient safety as a strategic priority. It's not a separate thing that hospitals need to be focused on, or that, you know, healthcare professionals need to be focused on. So we really want to reassert patient safety as a priority for healthcare organizations. And one of the things, Olivia, that I see in my work is that hospitals and healthcare executives tend to think about patient safety as one of the things that they have to do, one of the many things that they have to do, rather than seeing it as how do we integrate patient safety in everything we do. So that's a big focus for PFPS US. And then, you know, we also want to establish greater national oversight of patient safety, because we know that when, you know, if we just tell healthcare executives, hey, you should pay more attention to patient safety, well, you know, there's a lot of other things that are going to get in the way. So what's really going to be powerful is getting the government to make requirements for these changes that need to happen. And so, you know, Olivia, we've got work happening here in the United States. I know you're familiar with the work that's of the PCAST organization. This is really exciting for us that we have the President's Council of Advisors on Science and Technology, or PCAST, For the first time, this is a group that very specifically makes recommendations to the President of the United States about how we can change federal policy around patient safety. And PFPS is very supportive of that. And actually one of our founders sits on that team. So yeah.
Yep.
And so tell us about the UK. What's happening in the UK around that?
Yeah, and I think it's what you had mentioned, as we were starting this dialogue is so incredibly important in that it is imperative that patient safety is established and hardwired as a strategic priority. And you'll notice for PFPS US, that is the first strategic priority for PFPS US is hardwiring patient safety as a strategic priority across the healthcare landscape. So I think that's, really important that that's front and center. And there are a number of things, as you alluded to, that we're working on to sort of forward and progress as this mission and vision and goal. So as Donna mentioned, there has been a lot of movement recently from PCAST, President's Council of Advisors in Science and Technology. One of our founders sits on PCAST, and so we're getting a little bit of the inside scoop into some of the things that have been recommended. But this is now publicly available. Some of the report of recommendations from PCAST is available to anybody online, so you can go ahead and download that. But some of those priorities really resonated, at least here in the States. I've heard this is, sort of colloquially, I've seen this in the evidence that patients consistently fall through the cracks in our fragmented and sort of patchwork quilt that is our regulatory and patient safety oversight landscape. So one of the key recommendations in PSERF is to appoint a patient safety coordinator who is reporting to the president on some of these key themes and issues and data and risks related to patient safety, kind of having that one central person involved in that reporting role. And really that was kind of one of the first steps in establishing patient safety as a strategic priority. Some of the other areas that we're working on are creating multidisciplinary national patient safety teams within the Department of Health and Human Services. The PCAST report also focuses on advancing technological solutions to address patient safety. So I think it's beyond the scope of time that we're allowed now, but certainly go and look at that report and see some of the things that have been generated from a key team of experts who are informing the presidential recommendations for safety. It's interesting because, as I mentioned, I'm kind of working transatlantically right now. My full-time role is at Hopkins, but I am here on a 1.5-year research contract in the UK. And it was interesting being here because I'm keeping an ear to the ground on some of the advancements in the UK as it relates to patient safety, of which there are many, and it's a very exciting time to be here. But one in particular that is very exciting under this PFPS priority of establishing patient safety as a strategic priority is that of the UK's or NHS England's PSERF, or National Safety Patient Safety Incident Response Framework. And the reason this is so significant is because organizations across NHS England were recognizing that they were spending a lot of time and resources investigating prescribed safety events that may or may not be congruent with the risks that feel real to them in an organization. And they were spending so much time on the learning and the investigation process itself that they weren't able to operationalize some of the actions and lessons learned that they learned. There were a number of other reasons that galvanized the implementation of PSERF, all of which are very exciting. One I want to focus on in particular is that of the 4 key core pillars within PSERF, the very first one is compassionate engagement with those affected by harm. I think that wording is very appropriate in the context of this discussion, in that, of course, that very directly speaks to patient and family member engagement after harm. But that also speaks to the need to compassionately engage some of our staff and clinicians, especially nurses who have been affected by the harm. So this offers an excellent opportunity to engage, all of these groups together in building solutions going forward. And so just on a logistical note, PSERF has been implemented in all NHS hospitals as of September of 2023, after a few years of piloting this framework. So now it is a national, essentially requirement for NHS organizations, and it's really exciting that the first priority is
Hello, Annie members, healthcare professionals, and students. Thank you so much for
of the high reliability principles, which is deference to expertise. We typically talk about that principle when we are saying defer to the front line to understand how work is actually done so that we can introduce new technologies, detect risks, make workflow improvements based on how frontline work is done. But I think particularly in the context of patient and family engagement, that principle applies more than any. And with that mindset in mind, as we're going into boardrooms, as we're going into the bedside, that deference to expertise, the expertise being the patient, is a key way and mindset that nurses can take forward as they're advancing some of these priorities in their own organizations or their own countries.
That's right. That's right. Yeah. And I mean, we can engage patients in their own care as well as in creating improvements in care. And it's interesting when I go and I talk to healthcare organizations across the country, they're very proud to show me the performance improvement work that they're doing. And I ask them, so do you have patients and family members that sit on that team? And generally, generally the response is no. Sometimes the response is, I know we should, but it's really hard to do that. So, and it can be really complex to involve patients and families to that level of improving safety in an organization, but it is possible. And getting their voice is the only way that we're really going to understand what is happening. And I know, Olivia, you and I both have experience with the healthcare system. And when my first husband was diagnosed with cancer, I was a critical care nurse. I thought we had the best healthcare system in the world until I was on the other side of the bed. And then suddenly I realized I was seeing healthcare through the patient's eyes. And that is what that's really what we need to be doing here, is remembering that unless we are patients or we are the family member of a patient and experiencing that, we really don't know what they're going through.
Yeah, what an excellent example. Thank you for sharing that.
Yeah.
Well, I recognize too that we could definitely go on about this for quite some time, but I think those first two PFPS priorities were the key ones because they touch every area of the healthcare system, and it really is establishing patient safety as a priority and patient and family engagement. So I think the subsequent three, not that they're less important, but we can speak to these within our given time here. And that next and third priority for PFPS is patient safety reporting. So this one's really interesting because this has been a hot topic in the US and in the UK, and we'll specifically highlight some of the advancements in both countries with kind of very similar oversight bodies. So the first one in the US is legislation that we are pushing forward to advocate for the National Patient Safety Board. So keep that in mind. I'm going to touch on the Healthcare Safety Investigation Branch in England first, because that one's already established, and then we'll come back to what is the US trying to do to emulate HSIB, or England's Healthcare Safety Investigation Branch. So England's Healthcare Safety Investigation Branch was established in about 2017 or 2018, and essentially it is an oversight body that investigates some of these key patient safety risks or harm events across England. One of their key priorities, and even more so as they're undergoing organizational change right now, is engaging patients and family members in the investigation process itself, but also allowing patients and family members to submit concerns or risks or harm events that they have encountered before, so that they have the possibility of being investigated by HSIB. So again, without getting into too much detail, but do want to emphasize that in the US, we've recognized the value of having an oversight body of a similar caliber. So we've learned from England and Norway and Finland and many of these other countries that have a very similar oversight body to inform our legislation for the National Patient Safety Board. So Donna, do you want to talk a little bit more about that in the US?
Yeah. And a lot of folks here in the U.S. and across the world are familiar with the national, here in the U.S. at least, the National Transportation Safety Board, right? So we all know that whenever there's an aviation event that occurs, there is an immediate examination of the root causes of the error that happened, and that's exactly what we're trying to do from a patient safety standpoint is have a patient safety a board, a national patient safety board. And so what's great, I think, about what's happening with the PCAST that we spoke about before, that the Presidential Council and Advisory Group, is it's one of their recommendations that their recommendation is appoint a patient safety coordinator that creates a multidisciplinary national patient safety team that collects that data and makes that patient safety reporting more transparent, so that we can really learn from each other. You know, for so long, organizations that had patient safety events would do an investigation internally, but not necessarily share their learnings with their peers, with other hospitals, right? So, and you can bet that if there's a problem happening in one hospital, it's happening in all of the hospitals. And so, wouldn't it be great if we could all learn from each other and implement things together instead of competing with each other?
Yep. Okay, so 4 out of 5, and again, knowing that we're kind of getting to our time here, but all of this information, we're very happy to speak to this further. It's all available online, but we'll kind of move on to the 4th PFPS strategic priority, which is transparency. So this one is not new, but this one is incredibly difficult for a number of reasons that you all may be very familiar with. But essentially what we're saying here at PFPS is transparency, requiring standards for timely communication and disclosure to inform patients, family members of harm. Really, so that's kind of on the harm aspect, but then on sort of the day-to-day care aspect is really reviewing and enforcing the standards to allow patients to have access to their medical records. So 2 different sort of tracks for transparency there. So sort of one after the harm event, and then one kind of in that sustained care going forward, but both very important to engage patients and family members in patient safety. Donna, is there anything that you want to comment on related to that?
I do, because, one of the things I want to remind the folks here at Annie is that nurses have a really powerful role here in transparency. And, not only to be able to be transparent with patients and families about the errors that occur, but also be transparent about the errors that are happening in their organization. There's a saying, if you see something, say something. Right. And so I think that's so important for nurses to remember, and nurse leaders, that, we see a lot and we can do a lot to improve. So, but let's definitely talk about our 5th priority, so that we can let these folks move on to their next session, which is the safety of clinical practices. And that is, essentially the all of the work that we've been doing for the last 20 years in performance improvement have been geared towards making, safety in clinical practice more efficient. But I think, I'd be interested in your thoughts first, Olivia, before I talk about what I think, because, I have a lot of thoughts on this subject.
Oh, well, so, something that I've been seeing more and more recently in the US and in the UK is it's no longer enough to engage patients and family members on a one-on-one or ad hoc basis, or as deemed sort of appropriate based on individual conversations in individual organizations. So although nurses quite often will do everything they can to engage patients, family members themselves, patients and family members are starting to see that the burden cannot just rely on the individuals to engage them in their care, and there needs to be major systems changes to make sure that they are meaningfully engaged in their care and can be engaged to prevent some of this harm going forward. So recognizing that very, very often their care team members are doing everything they can to engage them in care, and there's a need for significant systems change to kind of take that to the next level where it needs to be.
Yeah, I couldn't agree more. And that speaks to the work that I do on a regular basis, right? We talk about creating highly reliable systems, about creating resilient systems. What we mean by that is that no matter what is happening, no matter what crisis is occurring, whether it's a staffing crisis or a leadership change, or God forbid, a world pandemic, we are still maintaining safe processes through those crises. We don't have that in healthcare. There isn't one single organization in the entire world that is as highly reliable and as safe as the aviation industry or the nuclear power industry. We have a lot of work that we can do to be able to get there and create those systems, but we can't do that without nurses. You know, nurses are the core, the backbone of healthcare. We're the ones that are at the bedside, right? It's the only reason why patients even go to a hospital in the first place is so that they can receive 24-hour nursing care. So without nurses helping to create those reliable systems, we'll never get there. So so I'm really excited to partner with Annie now and in the future to work with you all to create those reliable systems in India and to help to elevate the voice of patients and families.
Well, thank you everyone for having us here today. I know that there are a number of other programs throughout this conference that will be of great value to you all, but certainly Ms. Thankum Gomez has done a phenomenal job organizing this conference with many of her colleagues, and she will have resources to which to direct you if you are seeking more information about Patients for Patient Safety US, the WHO's Global Patient Safety Action Plan, or anything else that we have discussed here today. So thank you everyone for joining us.
Thank you.
So let me give thanks Dr. Prasad and Olivia for such wonderful discussion on patient safety, engaging patient safety outside India. Very relevant points have been brought up. Like Dr. Lalu said, that it has to be a systemic change. I think they have spoken about it. And already those countries are way ahead. And I think we have lots to learn from them, right? Another thing, very important point, which I picked up from their discussion was about having a very resilient system like aviation and nuclear power industry. Now, what I understand from aviation is that, you know, however experienced the pilot is, but before every flight, there is a checklist which has to be filled up every time the pilot takes a, you know, every time. So in healthcare industry, is it possible for us to take a checklist and fill up for every aspect, especially when it comes to critical processes and when it comes to patient safety measures? Can we, or do we have that much of time or that much of, you know, SOPs or the processes, or even that, you know, that within us that we have to fill up a checklist? I think when we get to that level of ensuring that checklist and review of SOPs are done prior to doing any of the patient safety procedures. Of course, definitely we are into this safe surgery checklist. We are doing it, and most of the organizations are doing it. And yet we see that there are some errors which still happen. Wrong surgeries do happen. So probably people may be just filling up as a paper and not taking it seriously. I think there is lots to be done for us to come towards, you know, bringing up the levels of the patient safety in our own organizations. So anything, Dr. Lalu, Mr. Somital would like to add on to Dr. Prasad's and Olivia's discussion?
You know, I would just say that, and I'm repeating myself, that I think the spirit is more important than the letter. And just to, and I'm not being cynical here, you know, NABH has so many parameters, 600 parameters that all of us go through before we get certification. But then does it become a tick in the box? Right, because we know that assessors will come, we do a great job when the assessment is happening. I went to a hospital looking out for the rights of the patient, which are supposed to be written, but they were written somewhere, not a place where a patient will read them. So you did complete. So, you know, when you say checklist, we don't want a situation in India where we have to submit that checklist to the FAA or the DGCA, which is in aviation, right? The penalties associated. So we don't want the regulators. So when I heard them talking about president getting involved and, you know, from top down, this is something that has to come from bottoms up, right? Mm-hmm. All of us should feel for the patient because we are all patients. Today it's happening to somebody else, tomorrow it'll happen to us. So I have a little different view. Yes, if you can regulate it, then again, it'll become tick in the box. So let's do it in the right spirit. We'll all work with you. We know that you work hard. But let's stop this one thing, which is patient harm.
Yes, I agree with you.
Yeah.
Yes.
So just my thoughts on this. Certainly all our international patient safety goals are revolving around those major harms, the never events that should not happen in a healthcare setting. So we focus to a lot, I should say, time and efforts are put in to prevent any of those never events from happening. And the best example that you brought out is surgical safety checklist. So certainly a checklist cannot become a tick list. It has to be with the right intent to prevent something from happening. So I think that happens only when the culture sets in an organization. So it is not just a lip sync of patient safety, but everybody in the organization, starting from the doorman to the chairman, everyone starts talking about patient safety, takes these incidents very seriously, does a thorough investigation, and make sure that things don't happen in future. And we follow them. We don't have to reinvent the wheel. There are several good practices. It's a matter of just implementing those to the right intent and spirit. So I think the international patient safety goals are there to prevent these kind of never events from happening. That's one. Second thing is about the regulator and the DGs, like the airlines accidents and the nuclear accidents. See, we have to understand one major thing, which is if there is a small mishap in a aircraft, it's about 300 plus passengers. And if there is a small mishap in a nuclear power plant, it is 3 million probably, or 3 lakhs. So, those are extremely, extremely crucial. Now, if we are going to be talking about one patient safety incident, and for a regulator to get involved in such, nobody will ever practice medicine. So that is where it's extremely important that we as healthcare providers start self-regulating. So as Mr. Som said, it has to be driven by the healthcare providers to self-regulate, learn from each other, do not make it like a police investigation with a FIR kind of a thing. Patient harm will happen. How do we learn out of that is what we need to understand. But if we don't self-regulate, we will get regulated. That time it's going to be disastrous. So it is time that we come together, self-regulate, learn from each other, use these examples to prevent mishaps from happening. That's my take.
Thank you so much, Dr. Lalu. Just a simple measure like, hand hygiene. Let us take the example of hand hygiene. HAIs, a simple procedure of hand hygiene can prevent lots and lots of infections and other problems which you may have in the patient safety measures. Two things, I mean, I recall, as one, and in one of my hospitals or as a nursing head, I always tell my nurses, please, whenever you go at the patient bedside, you take a solution in your hand and you do hand rub in front of them and explain to them, why are you doing it? So that, that develops a confidence also that, you have to tell them that I am doing this hand hygiene to protect you from infection, from getting infection from us. And second thing is when you talk about patient empowerment, we also tell our patients, there's no harm. You ask the healthcare provider, whoever is coming to take care of you, that did you do hand hygiene? Did you wash your hands? I think these two things of, two-way communication, patient empowerment and nurses, doing it in front of the patients, like Minnie had said earlier, communicating care, Spandan, communicating care. You start talking to the patients for every measure you take, specifically when it comes to patient safety measures. So they will also develop confidence in the healthcare providers, and they will also understand why these particular things are done. I think these are very simple measures in healthcare. If we are at least concentrate on simple measures, I think we can go a long, long way of preventing very complicated problems as well. Exactly. So I think we wrap up with this now. And the question and any questions anyone has it, they can put it in the chat box. Or do we have time for the questions?
We can take 3-4 minutes.
Okay. So anyone has any questions, can you please put it up for the team over here? Mr. Som and Dr. Lalu can answer the questions in person. And if we have anyone for the Olivia and Dr. Prasad, the ANEI team will go back to them and come back to us with their answers.
I would like to ask Dr. Lalu one question.
Yes.
That yes, everything starts simple. Everything has to start somewhere. So my question is that, are the management ready to listen to patients who are going to come in and be very critical about the services?
Yeah.
So it's a very important question to ask, because I have experienced that many years ago. Maybe we were not ready at that time. So my management told me, what a rubbish idea to bring a patient here, you know. So that was the end of it. And I thought I was doing something great. So, but then the total meeting was hijacked, and my CEO told Tankam, bad idea. So, I would like to hear from you, because right now I am not in hospital. So Dr. Lalu and
Yes.
can tell that, you know, are we ready, and, you know, how do we navigate? You know, you can't bring in only nice patients, then you don't learn anything, right?
Yeah. Tankam, I think you were way ahead of time. That's probably what happened. But certainly situations are different today. Management, everybody understands. It's not the same kind of a situation where we had a paternalistic approach. When my grandfather was a doctor, the best of the produce from the market would come to my place. Today, I don't get anything. My husband is heading neurosurgery. The only thing I pray for is not for them to get hit. So, you know, situations have really changed. We are also learning. Every violence in the hospital is teaching us valuable lessons. So, I think management has really understood the need for engaging, talking to patients. As Kawaljit said, focus group discussions with the patients, relatives, and the patients are happening all the time today that we notice in most hospitals. But the measure that we are trying to say is to establish and formalize a structure with regards to a patient advisory council, bringing them to giving them a seat in the table. I think that the situations are really changing, particularly with regards to NABH. Now, after NABH has come into the picture, accreditation has come into the picture, people have become open for assessments. The culture is slowly changing. People are open for data, presenting them more openly rather than manipulating the data. We are seeing that in the last 10 years of my assessment journey, I've seen this happening. So I seriously feel the time has come, and management will be receptive, not 100%, but as always, 20% will start, 20 will adopt that, and slowly we'll move on to at least 60 to 70%. And that's a big change if you are able to do that.
And I just like to add to what you said. You know, the world has changed as well. I think the investments that you're putting into healthcare are huge. And one thing which is important is trust and reputation. And it takes a long time to build reputation and trust, but very little time to lose it. And today with social media there, right, it's not only about this person who comes to the hospital and misbehaves or shouts or whatever, right? They put it up everywhere. And nobody wants to risk their life. So I think it's an imperative for us, both as healthcare providers and everybody else in the system, to ensure that we are raising the bar, because we don't want reputational risks. Majority of the time when people have a problem, they spread the word around. Very few people talk good things. They all talk about the negative things that happen, right? And we don't take chances. So I personally, all my interactions, thank God, with healthcare providers, CEOs, etc., I think I see a lot more commitment. I really don't think it's an issue. And if there are some places where it is happening, I think the change will happen. It's too competitive a world right now.
Very true.
Any more questions, anyone? Do we have time for one more question?
Yes, there are a couple of questions in the Q&A box. If you can look at it, there is one from Vidhi and one from Sandhya Shankar. Any of the
Okay.
panelists?
So
Okay.
Vidhi is asking, what are the crucial factors to be kept in mind while providing care to patients in day-to-day routine?
I think the major aspect is patient safety, engagement, talking to them, and everything will fall if we don't do that. So that's probably the most crucial. Just bear in mind patient safety and patient engagement. These are the two most important things that we must remember.
Thank you. And Sandhya Shankar, she wants to know how, as leaders, we can promote the environment, motivating our nurses to not to follow a company for doctors' rounds, but to participate in doctors' rounds. So this is critical for patients, and I think this is very important question. Yes.
Important. Yes, not just follow the doctors, just carry the chart and walk around, but to participate. I think that word, it's not just the patient to be engaged. It's the nurses also to be engaged along with the doctors to provide the care. we see that all the time. Sandhya is very correct. They just follow, take notes, come back. But that participate in that, that word is very crucial.
I think I have seen in some of our hospitals. I mean, when we take our consultants' feedback as well, and across the group, I have seen that doctors say only one thing: nurses are very scared, or they don't come with us for rounds. So this is forget participating or forget going on round. I can also see nurses are hiding actually. They don't even want to go on rounds with the doctors, which sometimes I wonder why is it? Is it because of lack of confidence? Is it because of the fear of the consultants shouting at them in front of the patients or relatives? There are multiple factors, I think, which we really need to address all these things. And then we can talk about participating in patients' rounds as well. I think this is very important, Shankar, that the Sandhya has brought up with. But I think it's culture of the organizations, and we have to talk about many, many more things. And tweak certain measures, we have to take care of it. I'm sure we'll be able to reach there as well. There's another question, I suppose. No, I think that was enough. Any other questions, anyone?
Hello, Annie members, healthcare professionals.
I guess we should close it because the time is up for.
Sure, sure, Ajita. I think yes. Thank you so much, Mr. Som and Dr. Lalu, Dr. Yalu and Dr. Prosser and who is the fourth one? Sorry, I'm forgetting the name now. Olivia. Yes, Olivia. Thank you. We thank you, all of you, for participating in this great conversation and sharing your inputs and your insights into this. And this will definitely lead a path, and help the organizations in our country to set up for and formalize and engage our patients in providing safety to them, so they will help us to help themselves. I think this is very important. And thank you once again, all of you, for this great discussion. Thank you.
Thank you so much. Bye-bye.
Thank you, everyone. What an incredible discussion we have had today. I have to say, the depth of insights, the passion, the diverse perspective shared here have truly made this an incredible discussion. As we transition to the next part of our conference, I would like to take a moment to express my heartfelt gratitude. Thank you, Ma'am Kawaljeet. Thank you, Mr. Som Mittal. Thank you, Dr. Lalu Joseph, Dr. Donna Prosser, and Ms. Olivia Lonsberry. Thank you for sharing your insights and contributing to the richness of the discussion. Next up, we have an incredible line of events for the afternoon. I promise you won't want to miss a moment of it. But as they say, all work and no lunch makes for a very hungry crowd. So I think it's time for a well-deserved lunch break, right? Go savor a meal and I'll see you back here at 1:10 p.m. sharp with your appetites for learning fully satisfied. Thank you.